Oh, I'll be brave if you're brave. I'll be brave, but only if you're brave. And it could be just you and me. We'll be family. Just wait and see.
Good evening, everyone. Welcome to those of you who are able to join us today during our Lung Cancer Living Room. I'm Danielle Hicks, Chief Patient Officer here at GoTo Foundation for Lung Cancer. And for those of you who aren't familiar with our Living Room program, it's a support and education series created specifically with patients and caregivers in mind, with the actual goal of just really bringing to you live and in real time educational talks from key opinion leaders in the lung cancer community, but most importantly, in a format and a language that's easy to understand. We know that people watching tonight come from all around the globe and consist of patients living with varying types of lung cancer and are undergoing various types of care. And we want you to know that we're here for you and that we believe wholeheartedly that educated and empowered patients do better. So thank you for joining us tonight. As some of you may know, you saw some of the things come out on social media. Tonight we're talking about health equity, sort of a health equity 101, part one of two. I think, most of us have heard this type of language kind of bubbling around for the last couple of years. And I thought it was important that our community really understands what we mean. What do we mean when we say health equity? When talking about cancer, equity is when everyone, and I mean everyone, has an equal opportunity to prevent cancer, find it early, get proper treatment and follow-up after treatment is completed. Everyone deserves to be treated equally. Some of the factors that lead to health disparities, including poverty, socioeconomic factors, lack of trust in doctors and medicine, low literacy, and inadequate health insurance, just to name a few. They really create barriers to good care along the entire care continuum, from prevention and screening through treatment and even end-of-life care. So some of the objectives tonight and what we're hoping you guys take away from this is not only that what is health equity, but what is the impact it has in the United States? What are some of the barriers to healthcare from a provider and a patient level? And what can we do? What can be done to address these barriers? And I'm thrilled tonight to have, my computer just stopped working. No. Okay, good. I'm thrilled tonight to have Shanada Monestime coming straight from GoTo. She's fairly recent to the organization, but she has been an absolute rock star ever since she started. And she works on our science and research team and really is devoting her time here at GoTo to health equity, to identifying the gaps and the barriers, and trying to figure out novel ways to fill them. So, Shanada, welcome. We're thrilled to have you tonight. I think with that, we can just kind of jump right in. And I'd like to begin with, how is the overall health population of the United States? What does this look like?
Yeah, well, thank you for having me, Danielle. Very happy to be on this platform. So I think that's a really interesting question because we literally spend the most money on healthcare. So in theory, you would expect to see that the United States have the best outcomes, but the opposite is actually true. There was a study that assessed the healthcare system in 11 high income countries, and this included the United States. I was really surprised, actually, to see that we rank lowest performing in several domains. And that included, health equity, access to healthcare, and healthcare outcomes. I think I would have expected for us to be somewhere in the middle. But being that the ranking was so low, it was a huge eye opener for me, especially when we spend the most money compared to the other 11 countries. So it really informed me that we have a lot of work to do.
Yeah, that's really helpful. And I think, the next question obviously would be, what are other countries doing that's allowing them to perform better than the U.S. when it comes to healthcare and healthcare delivery?
Yeah, I would say like a distinct feature in the top performing country that stood out for me was that they provided universal coverage and removed cost barriers. And I think that is so critical because inadequate health insurance coverage is one of the largest barriers to having healthcare access. And in the United States, we have several states that has not supported the Medicaid expansion. And that's critical because technically what the Medicaid expansion would do would allow for more low income people to qualify for health insurance. So for example, in the states where we don't have expanded Medicaid access, these are people that are usually single with no kids. And let's say they make less than $10,000 a year, they won't even qualify for Medicaid. So I often think about this population and say, well, what are these people, what are they doing and how do they have access to healthcare? So I think this further revisits my thought of, we definitely have work to do with ensuring that hopefully Medicaid expansion happens so we can be similar to some of the top performing countries that had universal health care.
And I know, Shanada, that we're going to talk a little bit later about sort of, this is a gap that's been identified, right, and how we may be able to work towards improving on it. But is there a theme sort of around which states are not participating in the Medicaid expansion?
Yes.
Or is it just, go ahead.
No, I was going to say, I think that's a great question. I think we see more of our southern states not participating. They also have a common theme of these are states where we have large disparity groups, like our Hispanic, African American groups as well. I think that has been the common theme. There are about 12 states. I don't have them all mapped out, but we would usually see it in our South region.
Right. I think, one of the things that we hear kind of rumblings about all the time is the idea of some, socialized medicine, which, is one system that delivers universal healthcare services. The government pays for everything, operates the hospitals, the healthcare providers. It's interesting to me, though, some of the arguments that sort of come against even something like that, right? In regards to the quality of care or higher taxes in order to cover government costs. So it's just interesting sort of for me to think about, like, how do we fix it? How do we make it better? One thing might not be better than another, but potentially some combination of all the ways that healthcare is delivered around the world. What communities?
Absolutely.
Mm-hmm. Did you?
No, absolutely, because no, I was saying I absolutely agree. I think there's going to be pros and cons to doing something like that. But when we see some of the other countries that are doing something and quite successful, and we also notice that their outcomes, when we look at outcomes, they're actually performing a lot better. It just gives us something to think about. Potentially, like you said, having a hybrid or doing something similar that will allow or at least increase access. And even if we can't increase access or universal healthcare, expanding Medicaid to, populations that are really at disadvantage to access and health is a good first step.
Yeah, I agree. And I think that's a good sort of segue into the next question, that being, what communities around the U.S. do you believe are impacted most?
Well, I would say in general, our healthcare system, we distribute services that are unevenly across populations. And the reality is that some Americans receive worse care than others. I really would say it has a lot to do with racism and discrimination that have implicitly and explicitly been an integral part of the healthcare system. Therefore, we typically would see more marginalized populations disproportionately facing worse healthcare outcomes. And the disparities are exacerbated for those who hold multiple minority statuses. And we usually classify that as intersectional disparities. And some examples are like, imagine someone who is, for example, Black, low income, and part of the LGBTQIA plus community, they would have worse outcomes than someone who is just Black alone or only in the low economic status or just in the LGBTQIA plus community. So I think that, those are some communities that we typically continue to see having disparities and worsen in health outcomes compared to others.
Yeah, and I think that makes a lot of sense, and something that I don't think a lot of people think too much about. The when you start to intersect those disparities, the outcomes just sort of get worse and worse and worse. So, why do you believe, Shanada, that healthcare disparities are occurring within these populations?
Well, I think that each marginalized population has its own story and history that we can really pick apart to help us understand, why is it happening in the specific population. However, I want to take some time to focus on the African American population because during the COVID-19 pandemic, it has really brought to everyone attention that this population has been impacted the most. Even when we look at our cancer rates for most cancers, we're noticing that African Americans often have the highest incidence and mortality rates compared to other minority groups. So I think we really have to talk about the lasting impacts of segregation through redlining, which has created these communities to face higher rates of poverty, food insecurity, having access to like lower education, and environmental factors that are, in these communities that contributes to poorer health. However, I would say in the general, the majority of racial ethnic minority groups are more likely to reside in areas that suffer from physician shortages, which is also a product of structural racism. And I also want to add that when minority populations encounter healthcare, marginalized populations, they often encounter provider bias and poor provider communication as well.
So, Shanada, you said something, and you said the lasting impacts of segregation through redlining. Can you explain that to the folks watching tonight?
Yeah. So what redlining typically did, it's almost, I think of it as gentrification as well, like where there's certain areas where Blacks were not allowed to live. There's certain areas where, they wouldn't be approved like through a bank to get a loan that would cover houses in certain areas. So by default, these states were naturally segregated. And through that segregation, that automatically allowed these communities to have lower access to education, to hospital services and healthcare. And I think it has had a long lasting impact because if we look at some of these communities that were redlined years and years ago, we still see similar poor outcomes where there's a large amount of, for example, like Blacks or African Americans living in these areas still exhibiting the long-lasting impacts of redlining. So again, we still start to see some of those same attributes that were intentional in the past now also continuing to impact the communities at large.
Yeah. So in a sense, it's just sort of passed down generationally, right? Is that kind of what I'm hearing?
Yeah, I think so.
No, go ahead.
Yeah, I think by natural default. So if you think of having like a population and there's so many structural factors against that population, right? So by default, if you don't have, for example, when we live in homes, there's taxes that we pay, and those taxes really is what help build and shape our community. But if you have low income communities by default, that was intentionally set up that way, these communities don't have those resources where those tax dollars are really driving education. So with the lack of education, by default, that's going to lead to maybe not having higher education status. By default, that leads to low income. By default, this really goes back to not having insurance, because you have to think about, do I pay insurance through my low paying job, or do I put food on the table? So by default, with the structural issues that happen, these communities are disadvantaged from truly advancing. And it was known that they have unequal opportunities to build wealth in this country. So it's hard to kind of like leave that community, but oftentimes you'll hear many people say, well, if I did it, you can do it too. But with those barriers, it's just very hard to kind of get out of that. So yes, generationally, we have seen generations kind of being born into that neighborhood, staying in that neighborhood, not advancing because of systemically, what the system pretty much has held them to, with the lack of resources. So we don't really see them progressing.
Yeah, interesting. So I think it's a good time to maybe segue into some of the specific barriers that you mentioned, such as provider bias and poor provider patient communication. Can you talk about this a little bit, how it occurs and what impact it has?
Yeah, well, I would say the literature really provides evidence that clinicians hold implicit bias toward racial ethnic minority groups, and that they treat and diagnose disorders differently compared to white patients. We also see with this implicit bias, there's usually less shared decision making and treatments being withheld, including clinical trials. And that naturally happens because of attitudes and beliefs that some clinicians may have toward different racial ethnic groups. So we know that racism exists in the country, but when you see this in the literature and the impact it has on health, how could we expect patients to truly begin the trust process? How do they not feel so guarded in healthcare? Feeling attacked or having their guards up, or wanting to believe that the provider have their best interest at heart.
So I just want to make sure that our audience understands when you say the literature provides evidence, there have been actual studies that look into this, correct? That have
Yeah.
identified some of these things. Okay, I just want to make sure that the folks watching understand that. And I want to talk a little bit more about implicit bias, because I think it does play a fairly large role here, sort of across the board. And when you look at the just the simple definition of implicit bias and what that means, quite often it's not something that people are thinking about. It's not something that they're doing intentionally. It's something that's sort of carried over from really sort of who knows where. Can you talk a little bit about that?
Yeah, of course. So you're right. It's something that happens unconsciously. It could be due to several reasons. Maybe things that you were exposed to as a child just naturally, or how you treat certain people, or your perceptions of certain groups that just naturally falls in the process. So if you encounter, like, there's people in the United States that have never encountered different minorities. So when they see them for the first time, it's like, what did the TV portray? What image did they get? So naturally, they're thinking, oh, well, this is how the population may be naturally. So unconsciously, you're making decisions based off of, assumptions, or based off things that you believe. So it's not something that's done intentionally. It's just what you think of a population based off what you were exposed to. And the literature actually showed that providers, when they did a study, they showed that providers had specific biases toward Blacks, Hispanics, and even darker skin tone patients. And it wasn't intentional. It was all unconscious based off like previous exposure or history or things that they've been exposed to that they naturally think, and attitudes that are developed toward these populations that naturally falls into how they deliver healthcare.
Yeah. I know that with all that being said, many institutions are aiding, right, with providing healthcare providers with cultural competency training. And I mean, from your perspective, do you believe programs like this are working?
Yeah, well, I think that cultural competency training for clinicians is a step in the right direction for sure. And, I think they have done, like, studies showed pre and post surveys, the impact that cultural competency training has done. But there are some flaws, in my opinion. This type of training focuses usually on cultural beliefs and practices. It also focuses on communication styles of certain racial, ethnic minority populations. So you become more competent when addressing certain population, but it often excludes other social determinants of health, such as poverty or unhealthy living environments or psychosocial stressors, different discrimination or racism that may occur. So I think that although the method is helpful, it doesn't really give physicians or clinicians with a really great understanding on populations and some of the social determinants of health that might impact them. So I think cultural competency, although beneficial, it does have some limited benefits to really reduce the health disparities that we're seeing.
Yeah, and it's interesting to kind of think about, when the decisions were being made around this type of cultural competency training, were the people in the room, right, that you were trying to help and kind of overcome some of these barriers, part of the decision making, even just around what that training should look like, right? Like, are we bringing all the people in that need to be in order to make the best decisions on how to move forward?
Yeah, absolutely. And I think that's kind of what my work is at the go-to, but I think that's really about community engagement, especially community-based participatory research. And what that really means is that if you truly want to develop changes or an intervention to impact communities and change some of the gaps that we're seeing, you really have to ensure that the community is at the table. You want to make sure there are key informants and stakeholders at the table. So when you're developing some of these trainings, the community also can inform the type of training to ensure that when providers are interacting with them, they are aware of all of the barriers. And I think that is critical for healthcare systems to really, continue to do community-based research. I think it can definitely change outcomes and bring about community-led interventions.
Yeah, and I know we're going to talk about this in just a second, but I think, you say this, you and I had talked about this prior too, but you look at the United States and how diverse this country is, right? So it almost to some extent feels like an overwhelming task, but how can healthcare disparities be improved from a provider standpoint, even given that, the US is such a diverse country?
Yeah, I think that's something that we do have to take in consideration is that we are getting more diverse. We are also seeing a lot of, mixture in races as well, increasing the diversity here. So I think that it's really important that whatever interventions come apart for providers, that they are ensuring that, from a provider standpoint, we want to make sure that they are aware of the changes and the diversity. So when they address the population, they are aware of how to improve patient-provider communication. I do think there are a couple of things that providers could do. One, I think the most important is just making sure that all patients are offered treatment regardless of stereotypes and assumptions of whether or not that population wants to accept treatment. And then upon offering, I think it's important to educate the patient on the requirements of treatment and set them up with a patient navigator or a social worker if you identified barriers. Research has shown that if patients are offered and educated, they would likely accept treatment, but most importantly, they would be informed. And I think that would be a critical part of building trust. And I really think that representation matters too.
Yeah, I agree. And I think, not to interrupt you, Shanada, because I know we've got a couple more points to make here, but on this one in particular, in this shared decision making, I think this is one area where I believe GoTo does a great job in helping to empower and educate the patient, right? And make them feel more comfortable going in and having these conversations with their healthcare teams. And that's really all I wanted to say about that. I just want to give GoTo a little pat on the back, because it is here, right, to help patients fully understand so they can have, these very, very, very important conversations with their healthcare providers.
Absolutely. I think that's critical and definitely something that more organizations we're starting to see doing. But the fact that we're at the forefront of this, I think it's definitely good for patients. But another thing I think that providers can do to really ensure that they're addressing some of the health disparities is to know that representation matters. So when you're in the waiting rooms or consultation rooms, it's important that they have some type of visual aid or symbol that represents the community you're serving. Even, for example, like when I walk into my doctor's office, I usually see like several magazines that represents people that look just like me. And I think this is just one example, but by doing this, it can create a space of comfort and belonging and really sends a positive message to the community.
Yeah, I agree with you there wholeheartedly. Again, going back to the diversity of this country, how many magazines can you put on a coffee table without it really looking like you're sort of tokenizing people, right? So I think there's a sort of a fine line in how we do that so that it is holistically representative, right? As opposed to just kind of throwing faces on the cover. So I agree with you, but I also think that's a little trickier than a lot of things.
Yeah, no, I totally agree, because you also don't want to appear like patients can sense when you're not being authentic as well, right? But I think it doesn't even have to be magazines. Like that's like an example, but sometimes you may go into Sometimes even in the consultation rooms, there may be pictures, or even some of the resources that you provide, it's very diverse. Or we even look at the staff that you hire, right? Like, does anyone in the staff look like me? So we may try to look for anything to identify with. So in any way that healthcare providers or healthcare systems can create that representation or visibility, I just think it really sends a message home for people that are coming into your community, especially to kind of almost mimic your catchment area. Like, what does the people look like? Do you have any representation, even if it's just one, or somehow the community is being represented in the healthcare system?
Yeah, agreed.
Yeah.
I know you've got some
And
other.
another, okay.
Yeah.
Yeah, I was gonna say something else that I did want to mention is that I think it's really important that providers they should really try to encourage patients to ask questions and truly understand their hesitations, because oftentimes patients, they may not be comfortable with something that's new, or they may be really unfamiliar with it, but they don't have the courage to ask questions. So this is where providers can really step in to ensure that patients feel, that their questions are being answered. And I know some providers are usually pretty busy, so if this can't be done, it's really important that they connect them with some type of navigator or other personnel that's familiar with the population. And this is not a robust list, of course, but it at least lists a few examples of a good start on how to help provider and patient communication.
Yeah, no, I agree. And I think, providers encouraging patients to ask questions. I know on the helpline quite often we have patients saying, well, A, I didn't know what my questions were until after I walked out of the room, right? So then what? But B, you look at these healthcare providers and, they've got entire days and weeks of their calendars being full. So the better educated, and I'm going to point back to this again, and empowered that a patient can be on their own, the more likely that's going to be a really positive and productive conversation, given some of the time constraints with your healthcare providers.
Absolutely.
So Shanada, let's jump to healthcare systems. What are some ways you think that healthcare systems could support the healthcare providers, in the right direction towards health equity?
Yeah, I think that's a good question, because without that support from healthcare systems, I think it will be very difficult to kind of create that culture. I think something that was really interesting is that, I went to a conference recently, and the speaker had asked people to stand up if disparities did not exist in their healthcare system. And surprisingly, there was a good amount of people that actually stood up. And I really just thought, maybe they're unaware, because I feel like disparities truly exist everywhere. They may not be aware, but I feel like we can only fix what's broken if we know about it. So I'm really glad you asked this question, because it is important for us to recognize that it's just not providers, but healthcare systems need to be supportive of this environment. And again, like I said earlier, so that they can create a culture that wants to aid in improving health disparities. And one way to do that is to ensure that you are measuring and collecting sociodemographic data in a disaggregated way that will allow us to better serve all populations and measure outcomes and performance.
Yeah, I think that's a really good point. And I know, again, at GoTo, we've been doing a lot of work in the health equity space, and trying to really understand the disparities and what's going on here. And it's just interesting to me, the point that you made sort of at the beginning of this, saying that, people were asked to stand up if disparities did not exist in their healthcare system. Because I don't think people fully understand sort of the laundry list that does make up disparities. I think, again, there is sort of what people think, what they think we're talking about when we're discussing this. And I think you said something earlier. I mean, it's something like even food insecurities, right? I think a lot of people walking around hear food insecurities and like, what does that mean, right? They don't understand there's actually people who are giving up food in order to pay for their health care, right? So I think there's a lot of work to be done. It's really across the board, to get people to fully understand the breadth and depth of this problem. And it's not just a US problem. I know that's what we're talking about today. These types of things happen around the globe, but I sure am glad we're talking about it. So
Yeah,
what
absolutely.
advice, Shanada, could you share with people living with lung cancer, to provide and prepare them to be advocates for their healthcare, regardless of the provider that they encounter. So we talked a little bit about, there, just like there are no two patients alike, there are no two providers really alike, and so that sort of regardless of the provider that they encounter, what are some things that they could do to prepare?
Yeah, well, I'm happy you brought up this question because, the NIH, among other programs, they're creating opportunities that would support more minorities going into biomedical science careers. Because research has shown that certain minority groups have better outcomes when seen by other minority groups, other minority doctors. However, the reality is that not every minority patient is going to have access to another minority doctor. So it is important to what you were saying earlier in the beginning of this and kind of trickled throughout our conversation is that, it's really important that we empower patients to be advocates of their own health. And this is actually a strategy that people have studied to really look at patients who are empowered versus those who are not. And patients who are empowered, they're actually able to ask more questions, advocate for themselves. They're also able to voice concerns or opinions. And patients who are empowered, they also have increased shared decision making and higher patient satisfaction. So something I encourage my patients, when I practice as a pharmacist, I was like, hey, if you're nervous to speak to your provider, why don't you bring a friend or a family member that you trust that is comfortable with speaking with the provider, with a list of questions that you have, and also making sure they self-educate. But a very tricky part of this is that oftentimes, especially if patients are going through a cancer diagnosis, it's very hard to sit there, read all the documents. You feel very overwhelmed. So it's like even just requesting for education brochures so that maybe you have a family member that can actually go through it and have questions ready. And usually there's someone in the family that's always the go-to for healthcare that can really help, patients that way. So I think even getting brochures or information for them is really important. Education is just to me, it's just critical in really ensuring you have the best outcomes, asking the right question, the best access to treatment. And there's even there's like a dose response relationship that shows, education attainment and health is correlated. So pretty much the more less advantaged you are, the more likely you are to experience a burden of poor health. So I think, again, same thing you said, Danielle, empowering patients to be advocates for themselves is just instrumental.
Yeah, it's interesting because I think about it and my role here obviously is sort of this patient first approach. And I try to put myself in their shoes, right? And if somebody had told me if I was newly diagnosed with, stage 4 lung cancer, you need to go out and empower yourself and understand what's going on. I guess my first question would be, where do I go to do that? Right. I mean, I think because health literacy, and I know we're going to talk about some of the work GoTo is doing there, but it's a real big deal, right? Most people, their inclination might be to go to Google, right? But then you go to Google and now you're reading all of these scientific papers with all of these really big words, and you're really trying to figure out what might or might not pertain to you. So I really think that even just suggesting empowerment without maybe and here's how you can, can find yourself there can be really overwhelming to patients, right? Of course I want to know.
Absolutely.
And not every patient wants to know. There are plenty of patients out there who are like, my doctor told me to do this. I didn't ask any questions. I don't want to know. I'm going to follow the rules. And that's sort of that, right? And everybody going through a lung cancer diagnosis should be able to make their own decisions. But I guess my point is, to reiterate it, is for those who are interested in educating and empowering themselves, I don't think there's a very clear path for how to do that.
Absolutely. No, there's not. And I know we'll talk about it later, but those are some of the things that we're working on here with the organization to try to create that path for patients. At least, how do we ensure that they have access to the right questions to ask, what to expect? Because there's, like you said, there's so much information out there. It's easy to get lost in the information or feel discouraged. But, I think having resources, like you said, available that you can trust and know how to navigate those resources, or even partnering the nurses or someone who you trust in the healthcare system. Like, did I ask all of the right questions? Even me
Yeah.
practicing as a pharmacist, I'll have patients that would ask me, like, did my provider give me the right medication? I feel like he didn't, or I feel like she didn't. Like, can you help me understand? So just finding that person that you trust, that you really authentically want to know, but maybe didn't have the courage to ask your provider. I think those are some ways to potentially go about it. But you're right, it is hard, especially being diagnosed with cancer, to begin navigating, what do I need to know and how to really process and access the care.
Yeah. And I think, even an added layer to that is particularly in more rural areas, right, where the general oncologist is treating any type of cancer that walks through the door, right? Whether it's a solid tumor or blood cancer, and there's 100, give or take, different types. And with how, particularly in lung cancer right now, with how fast and furiously discoveries are being made and things are changing. And this was, approved for first line last year, but, now it's over here and now it's over there. I think there's a lot of things that need to be done, including if we want to turn to the healthcare providers to be able to educate their patients in a way that is proper and current and what's happening right now. We also need to help support the healthcare providers and give them easy access to the information about what's happening right now. And again, to go back to some of the challenges we have that the people who call the helpline are having is like, well, I went to Dr. X in, small town Y, and they never told me any of this. Right. And on one hand, I can't really point a finger or shame blame that general oncologist, because how do you keep up? Right. And so I think, that as we, as technology evolves, or, maybe it will be easier for these guys and gals to understand how to best treat what walks in the door, or what type of lung cancer walks in the door, because lung cancer is not one disease. It's incredibly complicated. So anyway, I'll jump off my soapbox about that, but I do believe that provider education plays a big, big role here. So how do you think, Shanada, we could actually achieve health equity? Health equity, as we kind of stated in the beginning, where regardless of who or where you are, you have access to quality, up-to-date standards of care.
Yeah, really good question. A very difficult question, because I would say that, addressing health disparities are complex. You really have to consider the historic and contemporary inequities, and also think about factors that we talked about today that are within the healthcare system and outside of the healthcare system that patients are facing. And we often think that, healthcare is pretty much healthcare is pretty much what drives our health only. But when we think of healthcare in a clinical care setting, only 20% of healthcare really contributes to our health. That means we have to go beyond medical efforts and prioritize other things that are really critical to healthcare outcomes, which are what you talked about earlier: poverty, food insecurity, lack of access to quality education and stable housing. All of that is really the driving force to some of the disparities that we're seeing. So I would say that any projects or research or interventions that are being formed, it needs to be, all of these structural factors needs to be in place in order for us to really achieve health equity. Because we notice that within, some of the factors that we mentioned, it usually plays a role in our health and disproportionately affects certain groups.
Yeah, I think it's such an important point, so I'm going to reiterate it, that only 20% of our health is determined by the actual clinical care, actually what happens when you go in for an appointment with your physician. And I think, as you and I were talking about this beforehand, and because this is just as much an education for me as it is for those who will come back and watch it, to really take this deep dive into the sort of the infrastructure that creates, right? And I think quite often it can feel overwhelming. I know when I read it, it's like, where do you start? Where do we start? Do we start on the sort of poverty level? Do we start on the access level? Do we start on the education? It's a multifaceted problem. And to your point, I think the more organizations like GoTo, the more, academic or large community centers who, are doing this research, and other nonprofits, of course, the deeper we sort of dive into the space, I feel like that we're going to uncover so many things. But again, it kind of points back to which place do you start? And I don't know if you have like a personal opinion about that. It doesn't have to be a go-to opinion, but it does feel incredibly overwhelming.
Yeah. I agree. I wish I knew like the exact place to start, but I really think this goes back to the work that I do here. Everything is really community led. So it really depends on the intervention or what you want to achieve. It also depends on the health outcomes that you're looking for. And I think that would typically guide us to which structural factors do we need to really begin working on the most. And I usually utilize the community to help me understand, because every community is different. This is, again, where we don't assume. This is where the implicit bias comes in. We can't go in thinking, oh, this is this type of community, so we expect that you need this resource. I think that goes in the wrong way. So really, I think the best way to go about it is, again, having the community lead you to some of the things and the biggest barriers that inhibit their care, and really have focus groups to understand what are some of the barriers that they face. And then as researchers, what we would do is to develop some interventions along with the community that would be realistic to help us drive some of those health outcomes. So I think it would vary on which structural intervention needs to be targeted first, but I think they're all important in order for us to see, in the United States, to really see health disparities addressed. It needs to be targeted. We can't just target the problem. We need to look at some of the factors outside of the healthcare systems that are impacting some of the health disparities that we're seeing.
Yeah, I would agree wholeheartedly. And I don't think that there's a sort of one size fits all approach that we can take to this. I mean, to your point, I think we need to dig deep and, whether, it is having these focus groups within these different communities to really sort of get to the meat of or to the heart of and understand some of the challenges and the barriers and the problems. I think we're going to find that there's going to be multiple ways, or multiple programmatic areas or fixes, I guess, if you will, where that are going to need to be adjusted in order to really holistically look at and start solving this problem. So, Shanada, I know GoTo's got a lot going on in this space right now. And I wanted to touch on a couple of things with you tonight. So what are some of the things you're doing? Let's start there at GoTo Foundation for Lung Cancer regarding addressing health equities.
Yeah, absolutely. Something, even coming into the organization, just very passionate about the work. But the more I start to read the information and really understand what's going on from a community by community perspective, it just makes me wish I had a magic wand so that I can fix this, because we're talking about healthcare here, something that everyone should have access to regardless of social, economic, or demographic factors, but I'm really happy to be a part of the GoTo for lung cancer, because we are truly working hard to ensure that all patients at risk, diagnosed, or surviving lung cancer really has access to quality and equitable care. And some specific things in my role that I'm doing, I'm really taking the steps toward working with marginalized communities specifically, along with local institutions, to develop interventions that would aid in addressing and improving health disparities for patients, at risk for lung cancer. Even those who are diagnosed or surviving lung cancer. Most of my interventions that I'm creating, it really focuses on patient empowerment models. So exactly what you talked about, how can we begin to ensure patients have the right questions, the right tools to ensure that they're navigating their healthcare with a reliable and trusted source. So some of the work I'm doing really talks about engaging some of our communities to develop patient empowerment models, and also utilizing untapped resources. So we may have some other providers like pharmacists, right, that can refer patients to lung cancer screening that are working really hard in the underserved community. So we talked about providers being really busy. and maybe, that would allow for them not to really refer patients or may not have the time or resources. So starting my research would really tap into some of those resources that we're not utilizing to refer patients to lung cancer screening. And I think the biggest thing that I'm really excited about as well is collaborating with other epidemiologists that would help me explore zip code data, because we know county level data where lung cancer mortality and incidence is occurring, and we look at that by race ethnicity groups. But when we start to do zip code data, it would really tell us where in the counties should we have our strongest intervention, so that we go in strong with working with those communities and building partners and trust, so that we can begin to develop and identify some of those barriers, like what we mentioned, like what kind of structural barriers could we start addressing. So that's some exciting work that I'm working on right now.
So Shanada, you talked about patient empowerment models. So those exist today, and where they're being implemented, are they working? Are they successful? Or do even the ones that currently exist maybe need some tweaking?
Well, what something that has come out recently, I wish I knew the author right now so I can cite her, but they did something called patient activation. And this is where they walk patients with how to be empowered and this was actually a lung cancer study, where they used patients who have non-small cell lung cancer, and they demonstrated with this group how to be empowered. And they compared it to patients who were not empowered, and they actually identified outcomes where they saw increased shared decision making, increased communication, treatment actually being referred. So it really set the patient up. But some things that lack in a lot of these studies is that these studies are not in like African Americans or Hispanic groups. So we don't know how those patient empowerment models would work in marginalized populations. So some of the things I'm working on is to see how can we get patient activation and patient empowerment models in populations that haven't been studied yet, because that might look completely different with some of the cultures or beliefs and some of the barriers that different populations may face.
Yeah, and that's not an easy task, right? Because I mean, as we said at the beginning of this meeting, these populations also suffer from this sort of lack of trust. So it's like, before we can, maybe get them to participate and fully understand, we have to get them to trust us. And what does that look like? So I'm really excited that you're starting this at GoTo to try to really dig deeper, knock down some of those, those barriers, thereby empowering the patients. What else? What else has GoTo got going on in this space?
Yeah, I feel like I feel like we're doing so much, like in the different departments. There's a lot that we're doing. Even when we look at our COE, so Center of Excellence, when the the COE summit that we had recently, they also shared that GoTo is broadening our COE designations to include health equity and community engagement, which will track the performance of hospitals and clinics as it relates to their catchment area. So that's really exciting, because right now, nationally, we don't have anything to measure or, like key performance indicators for some of our hospitals as it relates to lung cancer. So I think it's really exciting. I'm really excited to see some of these designations come out, so that we can really strengthen those relationships.
Yeah, I would agree. And just for those that are watching, our COE designations, what we mean when we say that is there are centers of excellence. So we spent a lot of time over the last 2 years really developing this designation model, so that the 900 or so sites that currently have our Center of Excellence designation can really parse themselves out into these different areas. And I could not agree more. And they include multiple things, from screening and early detection to incidental pulmonary nodules, biomarker testing, so on and so on. But the fact that we are bringing this health equity and this community engagement into the actual designations, I think is going to be huge for us. Because like you said, there's not a ton of data in these particular areas. And we've definitely got centers around the country in these sort of, these areas where we can collect some of that and try to, become more informed, thereby better serving our community. What else?
Absolutely. I would say some other things that we're doing. We're developing patient resources to improve health literacy. And there are some specific projects right now that's tailored to the Hispanic population, to kind of help ensure that whatever materials that are created, it is in a platform that they're, receptive to, and that where they can learn the most knowledge from. And including our registry is also available in several languages, which is also pretty nice. And I think we're also grateful for platforms like this, so that allowed a space to discuss critical issues around health equity and to share with the community. So I think this is also a really important thing that the Go-To for Lung Cancer is doing. And another thing I wanted to share that's really exciting is that, we did partner with FSG to identify lung cancer disparities in different marginalized populations. And the first phase of that project is completed. And it has brought the organization great insight on the next steps to address the disparities. And I think what makes this so unique is that right now there is not one location that really describes all of the disparities, or like you said, the structural factors, social factors that are impacting the community. So by partnering with FSG, we were able to really understand that data, and understand from different providers what can be done for future interventions to ensure that we are addressing some of these gaps in these communities. So I think that's all really exciting. I'm sure there's more, but I know those are the main ones that really stood out for me that we're doing.
Yeah, I would agree. And I think, one of the things that's important, I think, to communicate out to our lung cancer community is part of this FSG work also included small cell lung cancer, because this in and of itself has been sort of this, disparate community that's been left in the shadows. And I think I know Go-To is committed to really working with the small cell lung cancer community, not only in helping, provide them access to care, but helping really just generate community around that diagnosis. I know, 15, 16, 17 years ago when I first started in this space, even our non-small cell lung cancer, people who were diagnosed with non-small cell lung cancer didn't have a community. They had no place to go. I remember early on people saying, I've never met another lung cancer patient, right? And that seemed so incredibly sad to me. And I think a lot of our programming, sort of sprang from that little nugget of information. And I think the health literacy piece is such an important part. It's not just literacy; it's also the language barriers, that kind of fall into it. And it's access to the information is part of the problem too, right? We want patients to be able to find it, we want them to be able to understand it, and we want them to be able to use it. So Go-To is very, very committed in all of these areas. And to Shanada's point, more. We are, we're in this 100%. So, Shanada, I know we've got about 10 minutes left, and we may not take up all of it, and that's fine. And I want to remind anybody who is watching live that if you have any questions tonight, please feel free to just put them in the chat, or if you have questions afterwards, feel free to reach out to us. And I know Shanada spoke about one author that she wished she could remember off the top of her head, but we will be sure to include it in the show notes that come out in our blog after this programming. But Shanada, what do you want people to take home from this? Like, what are your sort of high level take home points? The most important thing that you want our community to take away here?
I would say I think the most important thing is, I think what we can all learn from the health equity space is that it's important not to judge others, because you don't know some of the barriers or, different things that they might be facing. So I think as a whole, in a whole community, some things that we can do is, when we see something, say something, right? Or if you notice bias is going on in your healthcare system, say something, do something about it. I think that's really critical. I think it's also important, again, for patients that are navigating the healthcare system to always, there's always someone in the system or the healthcare system that want to be an advocate for you. It's really about identifying, trying to build trust, finding your trusted resources, whether it's a nurse, a pharmacist, your direct provider, a navigator, social worker. Try to identify that and then utilize that resource as much as you can, because many people in the healthcare system truly want to help. But it's about asking those questions, opening up, trying to let your guard down a little bit until you find that trusted source. Because I think there's so much that we can do in healthcare, but not everyone has access to that information. So really, again, just trying to empower yourself to get access to that information. And other things I want to share with the audience, because we have a variety of people listening, is to ensure that, again, we're continuing to include the community in all aspects of our research, in our education, in our resources, whatever it is that we are creating. Is really important that we include that community up front so we can get a good perception on how can we ensure that whatever we're producing, the community would be receptive to. I think that's often a piece that is often left out, and we need more of that. So I think those are some really important highlights that I wanted to make. And I'm just so happy that, everyone's in this space today, learning about health equity. I think even me, I consider myself somewhat of an expert on this piece, but there's still so much more to learn. So always be open to learning and being open to other people's opinions, because you just might learn something. So, I definitely am positive. I know we talked a lot about, the United States being on the lower spectrum of care, but I'm positive with all of the changes that are happening, we will begin to start. We're already seeing progress for one, but I think that, we'll continue to see progress, especially with organizations like GoTo that's fighting to really empower everyone and leave no one behind. I just think, that's really important. So thank you again, Danielle, for this space.
Oh, you're welcome so much, Shanada. Thank you so much for coming in and talking to us about this today. I think it's also incredibly important that we all kind of wrap our arms around this and work together. I know at GoTo we're big believers in partnerships and this sort of sense of belonging. So I'm excited to see what's coming next. Speaking of what's coming next, our next living room will be on December 20th, and it's Health Equities Part 2. It's going to be around community perspective. So what we hope to do there is take this high level, what we learned today, and bring some real world stories behind it. So people who have been diagnosed, who have walked through and sort of suffered from some of the inequities, as well as the folks that are working and sort of, at the front of the line to try to help solve this very big problem. So please join us on December 20th for that. To get regular updates on this programming, as well as any information on other GoTo patient programs and services, please consider joining our patient and caregiver community at gotofoundation.org/living room. Thank you again, Shanada, for taking the time. I know you're on the East Coast. It's late for you. Thank you to all of you watching live or post live. Thanks to Penn Media on the back end for putting this production together. And of course, the entire GoTo team for everything they do for this community. I have to also thank our supporters. So Amgen, AstraZeneca, Boehringer Ingelheim, Bristol Myers Squibb, Daiichi Sankyo, Eisai, Foundation Medicine, Genentech, Janssen Oncology, Merck, Mirati Therapeutics, Novartis, Regeneron, Sanofi, and Takeda. Thank you for all the support and recognizing how important this programming is to the communities that we serve. We'll see you guys all next month.
Oh, I'll be brave if you're brave. I'll be brave, but only if you're brave. And it could be just you and me. We'll be family. Just wait and see.